Welcome everybody to today's clinical meeting. We would start with our first presenter, Dr. John Roy from Medicine One.
The topics for today for Medicine One, its title can't get you off my mind. The story is that of a 43-year-old housewife from Walaja who's come with fever for 2 days, nasal discharge for 2 days, and altered sensorium for 2 days. So the fever was low grade, intermittent, without chills or rigors. The nasal discharge was a clear and watery type of nasal discharge, but she was not able to give a history of whether she's able to sniff it back or if it increases on forward bending. There's also a history of altered sensorium. She was mixing up the ages and the names of her sons, and she was not oriented to time when she presented. And she had a mild bifrontal headache. So all of these features were all just over 2 days. So very short history of these three symptoms. There was no seizure, drowsiness, giddiness, incomprehensible speech or paucity of limb movements, no nausea, vomiting or blurred vision, no trauma, no risk factors for HIV. So past history was significant for recurrent meningoencephalitis in 2012 and 2014. She was admitted here in CMC for those two periods of those two admissions, and at that time she had presented with the similar symptoms: fever, headache, altered sensorium, and one of the admissions also had a history of seizures. Extensive evaluation at that point of time did not reveal any cause or pathogen. So she was treated with a brief course of IV antibiotics during those admissions, and after each episode, she recovered without any residual neurological deficits or sequelae, and no specific cause was ever found. She's also a hypothyroid patient on 100 micrograms of well-thyroxine and hypertensive on oral antihypertensives. When she came, examination was significant for pallor. Other than that, she was hemodynamically stable. She was not oriented to time or place, and CNS exam was normal except for the presence of neck stiffness. So the clinical syndrome is that of a recurrent meningitis. And based on the history and examination, if we were to characterize it further, it was recurrent brief episodes of meningitis followed by spontaneous recovery with symptom-free intervals. What would we consider as differentials at this point of time? So the differentials for a recurrent meningitis is what we are looking at. Clinically, as of now, we only know that it's recurrent meningitis. Let's proceed. So the differentials for recurrent meningitis are actually quite broad and could probably be divided into 4 broad subcategories: infections, structural causes, drug-induced or autoimmune. And infections, again, bacterial, fungal, viruses or parasites. Structural causes, underlying structural causes that could be either acquired or congenital, which would result in a communication of the CSF space with the exterior. Drug-induced causes are there, which I think none of our patient was not on any of these medications. And autoimmune causes, these are all causes of recurrent meningitis, which is what we know so far clinically. So we proceeded with investigations. She had a anemia, which was, I haven't put the MCV. It was a microcytic hypochromic anemia with which was a hyperproliferative anemia. Otherwise, all her investigations were normal. The BBBS was negative, LFT, RFT, and blood cultures, chest X-ray, everything was unremarkable. The CSF studies were done, and it showed a CSF protein of 82 and a CSF glucose of 56 for a serum GRBS of 94. She had pleocytosis, which was lymphocyte predominant, 98% lymphocytes with 60 cells. And the culture just showed moderate pus cells with no bacteria. And the final report had shown no growth. Her viral PCR was negative for it was a multiplex viral PCR. The CSF expert was negative, and the MZ is still awaited. The biofilm array was negative for all the pathogens listed in the biofilm array, and the autoimmune encephalitis panel is negative. So we have a CSF study that is showing now it's looking like an aseptic meningitis with a lymphocyte predominant pleocytosis. Other investigations were done because as we had mentioned, there were a lot of structural causes for the recurrent meningitis as an etiology. So CT brain was normal. MRI brain with contrast was done with a whole spine screening, and CSF rhinorrhea protocol was also done. And all of these showed no significant abnormalities. It was absolutely normal. So, if we looked at the previous CSF studies during those last two hospital admissions in 2012 and 2014, she's had a similar aseptic meningitis picture with a lymphocyte predominant pleocytosis, as we can see here. So just summarizing, this is a 43-year-old lady who's come with recurrent episodes, 2012, 14, and 23. Recurrent episodes is benign because there are no long-term sequelae or deficits. Brief, or the history is a very brief history. It's a brief onset and a brief recovery. Episodes of aseptic lymphocyte predominant meningitis, and it is alternating with a symptom-free interval. Could we try the diagnosis? Could we try that now? So it's fulfilling the diagnosis is fairly classical for Molleret's meningitis, which is a benign recurrent lymphocyte predominant meningitis. So the diagnostic criteria was put forward by Brune, which again our patient fulfilled all of it. Attacks separated by symptom-free intervals lasting for weeks to months. In our case, it was in years, but he had initially put forward weeks to months. CSF pleocytosis, remission without any residual signs, and no causative organisms detectable. There is a small modification put forward by another person who said fever may be absent, and some patients may have transient neurological symptoms or signs other than meningeal irritation. And he had also mentioned that the symptom-free interval may be lasting for a few years. So these are very typical classical cells seen in called Molleret cells. These the green arrowhead here and the white arrowhead here and this one. So these are monocytes that are seen very acutely when the meningitis occurs. So it's a very transient phenomenon. You get it only in the initial days, and if we get this is very classical for Molleret's meningitis. So these are monocytes with a very deeply clefted nucleus, which is why you can see some clover leaf shaped nucleus here, and probably a dumbbell shaped and a bean shaped nucleus. So the presence of this would actually help us avoid a lot of detailed investigations, because this is quite classical for Molleret's meningitis. Treatment for Molleret's meningitis. So the hypothesis is that it's related to HSV2 infection. How they came to that conclusion is because they found a lot of association based on viral PCR and tissue cultures, where they found that patients with these meningitic features had HSV2 within them. But it's a very benign and self-limited illness, and people, though they administer acyclovir for it, for suppression or for a prophylaxis, but many people think that it really does not alter the natural course of the illness. It's benign and self-limiting by itself. Some methods like steroids, colchicine, antihistamines, and phenylbutazone, which is an NSAID, have been administered, but there's not been much benefit. There really is not much. There's not really much studies on this because it's a very rare condition. So to compare with placebo-controlled trial is not possible because it's rare. So for our lady, she was started on ceftriaxone, vancomycin, acyclovir, and doxycycline, pending the CSF reports. She had a very quick symptomatic improvement, and she was discharged with 2 weeks of acyclovir. The learning points from this case are just a general overview on recurrent meningitis and particularly Mollaret's meningitis.
You do a throat swab, she had some rhinorrhea.
She had, we didn't do a throat swab, but the CSF studies were all negative for rhinorrhea.
Any other comments, questions from the audience?
Whether it was cytospin or just staining,
Sir?
gram staining,
Gram staining was done and it did not.
showed the Mollaret's.
Oh, no. That's just a, that was not there in our patient.
The cytospin done.
Cytospin was not done, sir.
Interesting thought of my question.
Yes, it was not.
Because you had an iron deficiency anemia, was that worked up?
Yes, sir.
Was that worked up?
The iron deficiency anemia was worked up and it was secondary to heavy menstrual bleeding. She had a low iron PIBC, high TSAT. Yeah, thyroid and breast was examined and was fine. No goiter, no breast lump.